So good evening, everyone. Welcome back. This is our, I think, 10th session for this year, ACNS 𝑾𝑰𝑵 webinar. Today, we are most delighted to have our webinar chat by Prof. 𝒂𝒒𝒂𝒂𝒓, Professor of Department of Neurosurgery in Gunma. And we have three very exciting topics today to be discussed. And we also have three exciting discussants together with us today. Together with Prof. Abida, me and Prof. Abida will be the moderators today. So without much time, Prof. Kato, would you like to say anything before we start?
Just I cannot wait their talk. I think those three people is very excellent.
Yes, okay. So I will go ahead and introduce the speakers, but later I think Prof. 𝒂𝒒, you can take over for the discussions. Okay. So I will start off. So we have three discussants today, Dr. Dilshot, Prof. Raja, and Prof. Itichai. I think he just joined us. So for our first topic, it's with great honor, I'd like to introduce Prof. 𝒂𝒒𝒃𝒊𝒂𝒂. He will be speaking today. He's the director of the NPH Center and in Japan, and he will be speaking today on the topic normal pressure hydrocephalus as a cause to dementia. I think all of us are very interested to hear this topic. Without further ado, Prof. 𝒂𝒒 can start.
Okay.
Share your.
So I will talk about normal pressure hydrocephalus as a cause of dementia, and no COI for this presentation. This presentation is based on my personal experience with NPH and published epidemiological studies. And here is my personal experiences. I have seen about 2,000 patients with suspected NPH and performed about 90% patient lumbar tap. And then among the patient with lumbar tap, 70% patient receive shunt surgery. So the total shunted patient is dementia is a critical social burden, and well, it doesn't work. In the United States, about $290 billion are spent for dementia every in 2019, and it will go up to 1.1 trillion in 2050. The situation is almost the same in Japan, and in 2015, the total cost for dementia is about $112 billion, and it will goes up to 188 in 2060s. So, as you know, there are many causes of dementia. I cited from famous internal medicine textbook, Harrison, and the rest is very long. Here is our normal pressure hydrocephalus, and it is very famous for potentially reversible dementia. At first, I will talk about NPH as a cause of dementia, looking from dementia epidemiology. Very recently, epidemiological study in Japan was published in 2020. According to this, among the people over 65 years old, there are 8.5% of dementia, and Alzheimer's disease, vascular dementia, and dementia with Lewy body occupies about 90%. As you know, these diseases, there is no effective treatment. And NPH occupies only 0.3%. Japanese dementia incidence over 65 years old is 8.5%, and the prevalence of NPH in dementia is 0.3. So very simple calculation lead to the number that according to the dementia epidemiology, NPH is the number of NPH is 9,241, less than 1 million. So from the epidemiological study of dementia, NPH is extremely rare as a cause of dementia. A recent study have disclosed that about 35% of clinical Alzheimer's disease are misdiagnosed and maybe different diseases. And about 35% of clinical Alzheimer's disease are misdiagnosed, and they may be NPH, a reversible dementia. So we look dementia from epidemiological study of INPH. We have guidelines for INPH guidelines, and the key point for this is very complicated, but the point is very simple. The age is over 60 years old, and Evans index is over 0.53. There are symptoms such as gait disturbance, urinary incontinence, and cognitive dysfunction. And the image diagnoses include DESH, this is very famous, and TAP test positive. This is normal MRI, and this is typical INPH. It is well known, and according to the recent review study of epidemiology of INPH in Japan, prevalence of INPH in Japan in over 65 years old is about 1.6%. And this number includes only the patient with typical INPH. So from a very simple calculation, in Japan, there is about 580,000 typical INPH in Japan. I will show a typical case of INPH. This is 82 years old. He shows dementia, urinary incontinence, and gait disturbance. At first, I will show the surgical technique of VA shunt. This is a schematic view of VA shunt. Very small bar hole and 8 centimeter insertion of ventricular catheter. This is programmable valve and atrial catheter. The CT scan shows very simple straight catheter. It's quite different from VP or LP shunt. So I will show you the technique. At first, I determine the insertion and direction. Checking the using laser pointer. So very narrow surgical field. The open bar hole. And then expose internal jugular vein. I use direct insertion. So connect valve and atrial catheter. So it is very easy. Now insert internal jugular vein. In this patient, only 16 minutes. I calculated operation time. This is show medium with IQL. This is the obesity patient. This is a normal patient. The median time is 27.5 minutes. This is the 82 years old man. This is before surgery. And 5 years after surgery. 10 years after surgery. This is the chronological changes of MMSE. At first, he shows 22 and then reached to 30 after 5 years. Gait improved, modified ranking scale improved, so he reached best condition after 5 years. So VA shunt is effective for a long time in typical INPH. I will show you a typical INPH treated by VA shunt. This is normal, and these are a typical INPH. For example, third ventricular ballooning, anterior horn rounding, or ciliary fissure dilatation, or enlarged convexity subarachnoid space. Up to now, I have never seen experienced INPH patient with normal brain image. So many INPH patients show atypical images. This cross-match table of Evans index and dash evaluated by neuroradiologist is from the patient, INPH patient with positive response to VA shunt. And it shows that only 30% of the patient fulfill the image diagnostic criteria. It means that at least 3 times as many INPH exist who could be improved by VA shunt than would be diagnosed by the Japanese guideline. And the population-based study can, because there are about 580,000 patients with typical INPH, and there are 3 times much more INPH. So there are 1.7 million INPH patients in Japan. And the cognitive impairment in INPH about 80%. So the dementia from INPH is about 1.4 million patients. It's a very large number. In 2022, 1.4 million patients with dementia were able to be cured by shunt surgery in Japan. So, and then the situation of shunt surgery in Japan. This is a report from Japan Neurosurgery Registry. It shows that there is only about 3,000 shunt surgery for INPH every year. This is a hospital-based study, and it shows that only 12,900 patients consulted hospital, and the number of patients with INPH is 1.7 million. So only 0.76% of NPH consulted doctor. This is the number of shunt surgery calculated from hospital-based study, 6,700. So only about 0.4% patient received shunt surgery. Almost all of the patients do not chance to be treated. So I will show you other type of NPH. VA shunt effective is non-DASH patient. This is 81 patient, old patient. As you see, there is no DASH, and I think this patient will be diagnosed as brain atrophy or Alzheimer. But after surgery, she improved the gait and also MMSE almost to the normal level. This is the other patient, 70 years old female. She was diagnosed as Alzheimer's disease. She cannot even stand up, and just 5 minutes after the TAP test, she can stand up. And 4 years later, she can walk without a cane, and MMSE improved to normal level. So, these cases were categorized as Alzheimer's disease. VA shunt effective vascular dementia. I reported this to Asian Journal of Neurosurgery, this year's publication. As you see, there is a lacunar infarct, and he showed left hemiparesis. MMSE was 24, but he is TAP test positive, so I performed VA shunt. 5 years after, MMSE improved 27. This is another case. She was diagnosed as vascular dementia, and he was abandoned for about 2 years. MMSE was 10. At first, she in his wheelchair, but 2 years later, she goes up to 𝑗ungfrau with his family. This is another patient, 75 years old. He complained forgetfulness. This is the large infarct. So most doctors diagnosed him as vascular dementia, but TAP test improved, so I ran VA shunt. The MMSE improved drastically, almost normal. Before surgery, he did not complain gait disturbance, but after surgery, his gait also improved. MMSE improved 26 to 30, and he enjoyed the stock market for several years after shunt. These patients are categorized as vascular dementia. So we cannot say nothing about vascular dementia without lumbar TAP test. So next patient is traumatic dementia. This is he suffered from acute subdural hematoma and contusion. And he was bedridden for about 6 months. He cannot even stand up. But after surgery, he can run. MMSE is completely normal. 12 years late after VA shunt, he is still independent. And this case was categorized as dementia from traumatic brain injury. VA shunt effective brain tumor. This 77 years old female complained dementia, gait disturbance, and incontinence. Well, this is large tumor, and she was abandoned for 3 years by neurosurgeon. both neurosurgeon in a very famous hospital. This is the 8 years after surgery. Tumor was not removed, but before surgery, she cannot even stand up. But 8 years after, she's completely independent. This is the MMSE. At first, MMSE is a 4, and then gradually improved. It requires 3 years to get to reach the best condition. This is the other component. This is the TUG and MMSE and NPH grading scale. All component improved gradually. This case was categorized as dementia from brain tumor. So then I will show you NPH with Alzheimer. This patient is 83 years old, and his CSF shows very high phosphorylated tau protein and 70.5. It means that she suffered from Alzheimer's disease. But even after surgery, the ventricular systems do not shrink. But he gradually improved after surgery and reached to maximum 2 years after. This is a change of MMSE after surgery. At first, modified ranking scale start 2 and then gradually improved and reached to 0 6 months after. It continued to 2 years. But after that, because of his original Alzheimer's disease, he deteriorated very soon. The dementia in Alzheimer's disease with NPH can be temporarily improved for a couple of years by Shunt. So current epidemiological study of dementia is just like this: Alzheimer's disease, vascular dementia, and dementia with Lewy body. But in the future, about 35% will be NPH. Of course, current state is this, but almost all patients with NPH are overlooked. So treatment of NPH drastically reduce the social burden, I believe. This is famous Lucas Planacher's picture. Shunt is a fountain of youth. Don't miss NPH as a cause of dementia. Thank you for your attention. It's okay.
Thank you very much, Prof. Kiyoshi. That was definitely a very eye-opening and very informative webinar talk just now. I'd like to now invite our chair, Prof. Sochi Oya. Would you like to take over the discussion? Thank you very much.
Okay. Thank you, Dr. Takagi. Thank you for sharing your experience with us. Actually, all the videos you showed today were very surprising to us. Let me. Can we have any question from the audience? Does anyone have comments or questions? I'll be happy to accept them first.
So we have 3 discussions today, Dilshot, Itachi, and Raja. I think if anyone wants to go ahead and ask, I'm sure everyone has a lot of questions, definitely.
Yeah, sure. I have a question regarding what is the pressure inside that shunt system?
Shunt system?
What is the pressure of the chamber of the shunt?
Pressure. Well, at first I start about 140 millimeter H2O and then gradually decreased. And about half of the patient reached to the lowest level. In this system, 10 millimeter, 1 centimeter H2O.
Okay. So it is a programmable shunt, isn't it?
Yes, sure, of course.
Thank you.
So I think I have read the article about the pressure after the shunt. Possibly that's from a JNS, and I remember that it says that it's not necessary to lower the pressure lower
Yes.
than to the lower than
I know the
lower than the
paper.
12.
I know the
But you
you
think the lower the better?
VP shunt or LP shunt, and VP shunt or LP shunt are limited by body mass index. For the VA shunt, there is no limitation.
Go ahead, Dr. Akhaza. Yeah.
Hello,
Some guy
Professor.
is raising hand. Okay.
Yes. First of
Go
all,
ahead.
I would like to express my gratitude for a spectacular lecture. It has been truly eye-opening. I'm a young neurosurgeon from small country Georgia, and this is really the topic is on point, and I heard a lot of new things. I thank you for that. My question is, you mentioned that the CSF protein tau index was really high in one of your patients. Would we expect the shunt dysfunction due to obstruction of the shunt higher than in other patients due to the high protein?
Of course, the patient with high phosphate-related tau protein, it means definitely Alzheimer's disease. I have treated many patients, over 300. They improved. Of course, not all of them, but they improved temporarily. So even if the phosphorylated tau protein is high, I will run VA shunt if they have positive tau test.
Oh, okay. But is the dysfunction rate higher than in the other patients compared, or the same dysfunction, the same rate of complications?
A complication is the same. Yes.
Okay. Okay. And thank you very much.
And very important point is complication is very low for VA.
Okay.
Most doctors believe that complication is very high in VA shunt, but it's a very misunderstanding.
Okay, thank you very much. Thank you.
Thank you, Professor. I have several questions. Thank you for your beautiful lecture. Why do you prefer VA shunting over VP shunting? Is there any evidences regarding the complication rate, or is just surgeon's preference?
Well, of course, there is no evidence for the VA shunt superiority, but when I started shunt surgery for NPH 20 years ago, I select VA shunt. Before that, I have many experiences, LP shunt, VP shunt, but when I start INPH, the patient is very old, almost so the average age is about 78, and well, they have many complications of abdomen, and the very important point is physical property of VA shunt. The system is very short, and the difference between ventricular pressure and atrial pressure is almost constant. For VP shunt and the LP shunt, it depends on the position and the BMI. So I select VA shunt.
And I just wanted to know your opinion about one of the newest technologies, e-shunting. Have you ever any experience?
I think it's a very interesting, and Professor Abdel Malik started about 60 years ago, and but the point is, it cannot change the pressure. Shunt system insert very tiny tube. I'm very interesting, but I have no comment on that. In the future, it will prevail.
Yes.
Okay, thank you. Next to the Professor Pirzad. Go ahead
Okay,
and ask the question.
Thank you very much. I also asked the same question about the DP shunt and also the V shunt. That's okay. It's now I understand. Thank you very much. And for complication, what is your decision if you face with complication like infection or rejection and or occlusion? What's your advice? Thank you.
Well, for the first time, the complication rate is very low. Of course, there are many complications such as chronic subdural hemostoma because of drainage. I experienced about 50% of the patient shows chronic subdural hematoma, but they are very thin, and even they complicated with chronic subdural hematoma, the symptoms improved. And that's a very important point. And I have no experience of disconnection. Of course, there is some infections, but the infection rate is very low, about 1%. And the technique is very easy.
Okay, thank you very much. Let me take the last question from Iti. Iti, you raised hand. Are you there?
Oh, Professor.
Yeah. Hi, Iti.
Hi. And
question?
Yes, I have one question, Professor Takagi. Do you perform the about venous study before perform the VA shunt in every case? Because in some cases they have very small about internal jugular vein. How do you deal with these problems in some patients?
The venous
study, like internal jugular vein study before, yes.
Well, then change the side. If they receive venous surgery from right side, then change to left side.
Okay, thank you, Professor.
Okay, it seems the time to go to the second one. So Sharon?
Oh, I think, Prof, there's some questions from the audience. Just one.
Really? Okay.
From
chat box.
Yeah, chat box. So I think the first question is answered just now, Mikhail. What is the place of ATV for NPH? The second question is, Prof, how did you diagnose? Okay, the question is he online? Is he here? Okay, took off his question. Okay, so the other question is, yeah, from the audience, Oluwanmayowa, are you here? Yeah, you can go ahead and ask your question.
Okay, thank you so much, Sharon. Yes, it's Opera. Thank you. Thank you, Sharon. Thank you, Prof.
Well,
yes, thank you, Prof, for such an exciting lecture. I enjoyed it. I just have a few questions. My first question is, when you have patients who do not pass the TAP test, are there situations when you still go ahead to shunt them? And what would be your guidelines for those kind of patients? My second question is, how do you handle patients who do not improve after your shunt surgery? And then my third question, or my final question, has there been any study to compare VA shunts with VP shunts in normal pressure hydrocephalus? And if there has been, what do the results show? Thank you.
Well, your first question is lumbar tap test.
Yes.
Yes.
Well, I run lumbar test for the patient without normal image. We are very experienced neurosurgeon or neurologist, so we know very well normal image. And as I show you, accumulation of CSF is abnormal. Dilated third ventricle around anterior horn or dilated Sylvian fissure. I run tap test for this patient if they have some symptoms, gait disturbance. But in the patient with brain tumor, as I show you, I do not perform lumbar tap. I do VA shunt without tap test. And the second,
Dr. Takagi, she asked, what would you do if the patient do not respond to tap test?
Well, I run tap test again, and if they do not improve, I do not perform surgery.
Okay, thank you.
Thank you. Thank you.
And her second question is, what would you do if the patient do not improve after shunt surgery?
Well, gradually decrease the blood pressure, and if they do not improve at the lowest level, and then run tap test again. If they show improvement by the second tap test, then change the valve.
Okay. Okay.
Thank you very much.
Thank you.
And the third question is?
Is there any study to compare VA shunt and VP shunts in normal pressure hypertension?
Some studies, but it deal about complications. The outcome study, we have no outcome study for VA shunt and VP shunt, only about complications, I think. And the result is almost the same, VP, LP, or VP, VA, LP. There is no difference up to now. But as I show you, we need, I observed over 10 years. So there is very few study observing the patient, following the patient 10 years or more. And it is very important to follow up them very long. The problem is pending. It's okay?
Okay, Sharon, I think we can move to the second topic. Thank you, Dr. Takagi.
Thank you very much.
Thank you very much. I pass the introduction to the second speaker by Prof. Abida.
Thank you, Sharon. And now Dr. Anna has not yet joined us, so we will move to the third presentation. And I would like to invite Professor Otani, who is the clinical professor at Department of Neurosurgery at the Nihon University School of Medicine at Tokyo, for his talk on extradural anterior clinoidectomy. He's going to be talk about paraclinoid lesions and the anatomy of this clinoidectomy.
And I'm so sorry for delaying. So due to my unstable web. Okay, in this slide, I will start from this slide. So extradural temporal approach. So Professor Day, okay, can I start like this?
Yes.
So yes. Professor Day developed like this. As extradural temporal approach. So this slide approach provides us a wide epidural space enough to expose the anterior clinoidal process entirely. But on the other hand, this technique needs extensive dural peeling of the lateral capital sinus. So in this approach, so we can get the I cannot so use the slide animation. So I will use the next slide. So I'm sorry, so sorry. So in this approach, so we have to cut the meningoorbital band and have to peel the dura proprius. So we have to know that these anatomical components. So meningoorbital band is a periosteal fold between the periorbital orbital and temporal lobe. And the second, so lateral wall of the cavernous sinus is composed of the front two dura layers, so dura propria and periosteal duras. So sphenoid bone structures is composed of the anchored with three components, left wing, roof of the optic canal, and the optic strut. So these structures have to be removed for complete anterior clinoidectomy. So next, I will show the surgical procedures of this approach in actual operations. So orbital angle should be drilled out to get the wide operative view of the lateral orbital wall. So I usually, so CSF drainage will be needed in these cases. So I will open the Shunt fissure to drainage the CSF. After that, superior fissure and foramen rotundum can be confirmed. So next. So at first, we should fully expose the meningoorbital band and open the orbital apex. So on this time, anterior clinoid process was just removed from the sphenoidal lesser wing like this. So red line this. So next, just a moment, please. And the superior orbital fissure was skeletonized and unroofing to confirm the inner reticular layers for peeling of the dura propria of the lateral cavernous sinus. So as you see on this time, the area so surrounding blue line was removed, just removed. So I will show the reason why we need the unroofing of the superior fissures. So as a superior fissure, so dura propria is just invaginated under the bone. So we have to remove the bone to confirm the inner reticular layers. Otherwise, foramen rotundum and ovary is not such invagination is not confirmed. So, and the peeling of the dura propria is like this. At the time, we have to spare the sphenoparietal sinus, should be spare the dura propria side, and the meningoorbital band was cut and to confirm the inner reticular layers, like here. After this peeling of the procedures, we can retract the temporal lobe over the temporal dura. We can easily dissect the anterior tip of the anterior clinoid process. So next, finally, so now we can see the optic canal extradurally like this. Then we can expose the fully anterior clinoid process, and so after open the optic canal like this, so anterior clinoid process is just optic, so anchored optic strut. So we can easily remove the anterior clinoid process like this. So this is a step-by-step anterior clinoidectomy extradurally. So, so recently we have just developed drilling. So this drilling model, 𝒂𝒃𝒄𝒄. So I would like to show the this step-by-step drilling of the Clinoid process, but I'm very sorry, so I cannot use the animation in this situation. But this model, we can finally confirm these transcavernous approaches. Please, so I would like to show the so next time I will show in details using these 𝒂𝒃𝒄 models. So I will show the several clinical cases. This case suffers I'm sorry, the oculomotor nerve sheath meningioma. So we have firstly diagnosis that this tumor might be neurinomas. So we have decided to perform the gamma knife therapy, but after that 6 months later, she suffered uncontrollable lateral orbital pain. So then we have performed the tumor resection. So sorry, it's not so small one. So as I explained to you, the same surgical strategies and so extradurally and the drilling of the anterior clinoid process. So after that, intradurally, we have so shaped the temporal middle fossa and opens the oculomotor sheath nerve. So this is a tumors engulfs the oculomotor nerve. So we have to piece by piece tumor resection is continued like this. And this case is a little bit fused sphenoidal rich meningioma. So she suffered progressive worsening cognitive dysfunction. So this is the same way. So extradural anterior clinoidectomy and opening the optic canal. After that, extradurally, so we can cut coagulated and cut the main orbital band and peeling of the inner reticular layers. So and so at the first period of the operation, we can cauterize tumor feeders. So even if the tumor is so huge, but we can easily so like this optic canal is opening and under the so here is a clinoid, here's the clinoid. So to avoid dissect the inferolateral side or to avoid the oculomotor nerve injuries. So we can get the so precise orientation of the optic canal and the internal carotid. So intradurally, so deep vascularization is easily and precise orientation of the optic canal and internal carotid arteries. So and internal decompression is so fast and not so difficult. So these tumors. And the last one is Cavian sinus meningioma. Is so this patient suffered abducens and oculomotor nerve palsy and dysphagia in the trigeminal nerve area. So I'm very sorry to show the can you see the operative video? Not it's an
We can
obstacle
see
of that. Yeah.
Yeah,
I see. I see.
the
Sorry.
photos are in front of the video.
Okay.
But
So
that's
yeah.
fine.
Okay. Okay.
Yeah.
But so okay. So I'm sorry. So next cases I will ongoing the next please. So I summarize the pitfalls in these approaches to avoid so about 6 pitfalls. At first, to avoid the CSF leakage, and we have to do the spinal drainage and to avoid the opening the ethmoid sinus like this. And the second is venous infarction caused by sphenoparietal sinus. So sphenoparietal sinus should be spared on the dura propria side during peeling of the lateral capital sinus. So I have one patient to venous congestive and so to be caused by the sphenoparietal sinus injuries. So next, okay, pitfall 3 is heat and mechanical cranial nerve injuries. So we have to use irrigation suction, and recently performed the no drill techniques and using these micro punch and micro rulers like this. And the pitfall 4 is a breathing control from the capital sinus. So usually, so just only the put on the surgical cottonoid with fibrin glue is just only easily to stop the venous controls, but sometimes we have to so direct injection of the like fibrin glue to the capital sinus. So it's very safe to control the venous breathing from the capital sinus. And the pitfall 5 is meningovital artery and the central retinal arteries. Like these tumors, so retinal crescent is just only the meningoorbital arteries, so upper surprise. So we have to we do not have to cut the meningoorbital arteries. So we have just to spare the meningoorbital arteries to spare the optical visual acuities. So the final is so we have to confirm the so these anterocrinal process abnormalities. So 𝒔𝒂𝒂𝒓𝒔 and intercrinal osseous bridge, we have to, in these cases, extradural clinoidectomy is very, very difficult. So in these cases, we have to select the intradural clinoidectomies. So we come to the end of the presentation. I'm so sorry to present full animation or other videos. So, but I would like to these surgeons must knowledge anatomical structures and to avoid operative surgical pitfalls. Thank you so much. Thank you for your attention. Thank you.
Thank you so much, Prof. Thank you. I think it was a very good presentation. Don't worry, we learned a lot. All right, so I'll hand over the floor back to Prof. Soichi. You want to take over?
Oh, okay. Thank you, Professor Otani. What you want to, or you intend to talk, we can get it. So that's okay. So any questions from the audience? We have many young surgeons, I think, who are very much interested in this field.
Thank you, Professor. It was a great lecture indeed. We were able to witness the surgeries we're using those pictures, so don't worry about illustrations. I have no questions. Everything was clear for me, so thank you.
Shut. You have a question?
Yes. Thank you so much, Otani Sensei. So my question is, you have showed us two techniques of using instruments during the extradural clinoidectomy, using the bone wrongers or punchers, and using the drill. So in the later slides, you told us that you were using the bone wrongers or punchers. Do you think it's better or the same safety because of safety matters or what?
Yeah, thank you for your good question. So, previously, you use drilling. So you usually use the drilling, but so when just for the so optic canal opening and the clinoidectomy, we do not have to use the drill instruments. So it's just use the so micro punch and micro longers. It's full. I think so. So, but so it's so no drilling technique. We have to know the anatomical component. So today I would like to talk about and to show so for young neurosurgeons, so step by step for the extradural anterior clinoidectomy, just using only the micro punches, no drill techniques. So it's a step by step. So I think you can do it. And every so young neurosurgeons can do it. So after understanding the anatomical so, yes. I think so. How do you think about Dr. Oya?
Okay. I actually prefer to use I prefer to use high-speed drill. That's one of the reasons why I think like that is anterior extradural anterior clinoidectomy is a good opportunity for young surgeons to learn how to use the high-speed drill. So of course the educational purpose is not everything, but for me, I think I recommend young surgeons to use high-speed drill for this type of drilling, the bony work. But I understand your your meaning. Yeah.
I'd like to say, can I ask you one question? Can you hear? Yes?
Yes, we can hear.
Yes, I can. Yes.
Okay. So what is the advantage, the clinoidectomy for vascular lesion? Just tell us, because for young neurosurgeon is listening.
Thank you for your question. So extradural clinoidectomy is a very, very essential technique. I think so. And if so young neurosurgeons can get these techniques, so for safe such as for example the ICPC aneurysms or the low straighted. So to spare and to confirm the parent arteries proximal control. So it's very, very easy to So after the clinoidectomy. So I usually use, it's easy to proximal controls after the extradural clinoidectomy. So it's a very, it's a weapon. It's a very essential weapon for the ICPC or the vaginal or the yes.
Okay, so thank you. So the once you encounter the bleeding, how you can stop bleeding?
Yes. It's we can control the proximal control easily proximal control.
Or some bleeding from the cavernous sinus, how you can control the bleeding?
Yes. It's it's easy to venous bleeding hemostasis for the venous hemorrhage from the cavernous sinus. So just put on the surgical cottonoid with fibrin glue. It's very easy to put on the so hemostasis. Yes, but sometimes it's so for the it's not sometimes we use direct injection of the fibrin glue to the cavernous sinus, or just only the 0.5 milliliter of the fibrin glue to the cavernous sinus. So through the Dorrance triangle or the Maran triangle, yes. But it's usually it's easy to put on the surgical cotton and with fibrin glue. Not so difficult. I think so. Yeah.
Thanks.
All right. I have a few questions here from the audience. First question, Prof. Ohtani. What is the rate of optic nerve thermal injury after drill when compared with an intradural approach? And the second question is, does it affect selection of the approach if there is a middle clinoid process?
Yeah, thank you so much. Intradurally, so I did not usually use intradural clinoidectomy because I'm afraid to direct so clinoidectomy intradurally. So I'm afraid the heat injury of the optic nerve. So then and in my experiences, about 25%, nearly 25%, the heat injury was confirmed after the operation. So nasal or lower, partial visual field deficit was confirmed. So, but so patient is not reliable. So then I'm afraid heat injury of the clinoidectomy. So then I explained in my slide. So no drill technique will be useful to avoid the visual field deficit caused by the heat injuries. So, and second question is what?
Does it affect selection of the approach if there is a middle clinoid process?
Middle clinoid process. So in that cases, extradural or clinoidectomy is very difficult and we cannot do it. So in that cases, we have to select the intradural clinoidectomy. It's okay?
Yeah, I think, should be okay. I can understand. I'm sure the audience can understand. All right. So any more questions? Or do our discussants have anything to say?
I have one question, Professor Ohtani. Thank you for your presentation. Professor, do you routine perform the anterior clinoidectomy for ICPC aneurysm in every cases?
Thank you. So not so usual so do it, but not so usual. We have performed the extradural clinoidectomy, of course, but sometimes to proximal control for such as calcification is so tough in that cases, and my standard surgical indication for using the extradural clinoidectomy is between the anterior clinoid process and the proximal neck, the less than 2 millimeter, less than 2 millimeter. So we usually use extradural clinoidectomy because just only the intradural approaches, it's very, very difficult to confirm the proximal side of the proximal control in just intradurally. So it's okay.
Yes, it's okay.
Very
clear.
2 millimeters, less than 2 millimeters is very, very difficult because 2 millimeters is dural thickness, 2 millimeters.
If I may say one thing regarding the thermal injury which was discussed, actually when I was with Sensei Kato, I wrote a paper on the visual outcomes of paraclinoid aneurysms in Fujita, about 58 cases, and there are 2 cases of blindness altogether. And this phenomenon of heat injury has been studied extensively, and of course from Japan. It is there by Prof. Suzuki et al. And they have noted that when you drill, the temperature exceeds around 70 degrees, which is extremely hazardous. And even it can cause irreversible electrophysiological changes and permanent cell death in the optic nerve. When the temperatures of around 47 to 58 is reached. So safer, as you said, is with rongers, normal rongers with copious irrigation, of course, is mandatory when you do a drilling. And regarding the PCOM aneurysms, you talked about clinoidectomy. It has been extensively studied, and the recommendation that came from Prof. Lawton's paper is if the distance between the clinoid and the neck of the aneurysm, if it is less than 4 mm, you have to do a clinoidectomy. Otherwise, what will happen is your clip blades will not be closing. Okay, it will hit the clinoid. So that's why they always recommend to do a clinoidectomy.
Thank you, Raja. Any other comments? Prof. Oya, you have anything to say? Any comments?
Okay, let me say one thing. I'm kind of skeptical about the heat injury theory for postoperative visual deficits. I think because I have never experienced that. It's kind of, in my opinion, it's not easy to differentiate from, other type of injury to the optic nerve from the thermal injury, because we are going to touch the optic nerve after opening the optic canal for large aneurysms or removing the tumor. But as Raja said, I think the copious irrigation is a key to prevent or minimize the risk of heat injury. So I like to emphasize the importance of copious irrigation during skull base surgery or in all over, types of the skull-based surgery, skull-based drilling, I mean. So we do not have the third speaker tonight, right? And so maybe we can conclude this session. So I will return the microphone to Sharon, okay?
Right. Thank you very much, Prof. Hoya. Prof. Kato, would you like to say something before we end this session today?
Okay, so two topics are very, very common topics, and we learned a lot from both of them. Thank you very much.
Yeah, so I believe today both the topics, normal pressure hydrocephalus related with dementia, I think this is something a lot of us will face in the future as the aging population in the world, becomes more. So I think we should always update ourselves on that, so we don't miss the patients that need intervention. Thank you so much, Professor Kyoshi. It was really, really very eye-opening and a very good talk today. I would also like to thank Prof. Ohtani, because I think we have a lot of young neurosurgeons following your talk today. And I think everyone wants to know what is the right way to approach, like what Raja said, PCOM aneurysm or even tumors, the sphenoid wing meningiomas, etc. So thank you so much for your talk today. Thank you everyone for joining us. Thank you to all our discussants, Raja, Dilshot, and Itichai. It's so nice to have you all here and to continue to encourage the young neurosurgeons to join this webinar. Thank you so much, Prof. Kato, and thank you so much, Prof. Soichi, for being the chief today. All right. So thank you, everyone. Good night, and see you all.
ありがとうございました。
先生、ありがとうございました。